Thank you so much. So I'm going to be talking about behaviors that can commonly be associated with dementia. And I wasn't here for the first two lectures, but I did get a chance to read through their slides. And I think you're going to see a pattern of all of this education when it comes to looking after somebody who's living with dementia and what the priorities are. And I believe Dr. Misaki kind of touched on this a little bit, but there are changes in a person's action, their mood, and their personality that is associated with dementia. That is not just a person being stubborn or being in denial or being hard-headed. And so we need to remember that throughout the rest of this lecture, because this is part of dementia. This is part of the brain changes that occur when somebody has some sort of dementia illness. I did take a few things from the Alzheimer's Association and scattered throughout here. This is one of the first, that people with dementia have decreased or poor judgment. They are not just making bad decisions because they're just trying to make trouble for you, trying to make trouble for the physicians and the nurse practitioners and the caregivers and the family. They are physically unable to make good decisions when their dementia progresses to a certain point. People with dementia, and I'll talk more about this in a few minutes, but people with dementia often withdraw from work and social activities. This may actually be one of the early signs of cognitive changes to come. So someone may start looking like they're developing anxiety or depression, or they just want to stay home. And this is the first thing that we notice before we even notice significant memory issues. And then again, getting back to some of the slides from Dr. Misaki earlier, but people with certain types of dementia especially can have changes in mood and personality. So like frontotemporal dementia, which I believe she touched base on a little bit, or if somebody's had a stroke that affects certain parts of their brain, they can have marked changes in their personality. One of the most important things for everybody who looks after somebody with dementia, who is involved in the care, has them in their life, but that when people have any sort of significant dementia, they actually lose the ability to know that they have dementia. It's not denial, it is an actual inability to know that they have it. I was listening to one of the questions earlier that someone had asked about, do we need to tell somebody with dementia that they have dementia? My philosophy is when they come in and see me for a diagnosis, it is my job to tell them if they have dementia. Nobody needs to repeat to them for the rest of their entire life that they have dementia over and over and over and over again. It can be very demoralizing, and it often makes somebody feel like they're not being heard. And we'll talk more about that in a minute. So I may have somebody come in, I'll give them the diagnosis, and then as we get to know each other, I may start not using the word dementia quite so much, so that that person doesn't feel like everything in their life is dementia, 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 when they've lost the ability to know that they have dementia. It does them no good at all. Families absolutely need to know about the diagnosis of dementia. We need to get the diagnosis from families and friends and people who know that person well. Because again, the person coming in with dementia very commonly tells me, my memory's fine. They don't see it at all. So we have to have that extra history from everybody else. And why is it important to get this diagnosis? I think everybody's touched on that, but my 2 cents is we need to talk about treatment if that's in line with that person's goals. Not everybody chooses medications, even pill or IV. Everybody who can understand needs to understand what's happening. It is a lot easier to deal with behaviors that are associated with dementia if you understand that that person is not doing it on purpose. It is their illness, it is their disease, and it gives you a little bit more patience and a little bit more understanding, and it makes everybody's life a little bit better. And then future planning. I think this was also touched on a little bit, But if you have somebody with dementia, you need to think about 2 years, 5 years, 10 years down the road. Again, life expectancy for people with dementia is very variable. I've seen people with very quickly progressing illness that were around just a few years, and I've seen people be around for 20 years. But you need to have an understanding of what the future holds, and you need to have all of those legal paperworks taken care of. 1 second about that. Everybody over the age of 18 needs to have a medical power of attorney, and you need to tell that medical power of attorney how you want your care at the end of your life. So if you don't have it done, I think everybody in this room is over 18. They need to have their medical power of attorney. So how do we get the dementia diagnosis? And I know you went through a lot of this before, so I'm just going to go very quickly. But often this starts with a primary care physician. So if the person themselves is noticing it, you go in, you say, my memory's not as good. You may get a very short memory test, like a mini cog, which is the 3-item recall and drawing a clock. And then usually you get referred out to a specialist. So a geriatrician like myself, Dr. Chung, neurologist, or in some specific cases, something like a geriatric psychiatrist. That's not common. Most of the time it's a neurologist or a geriatrician, often determined by a person's age and the progression of their symptoms. Okay, so I've actually been asked this already once today. What happens if somebody doesn't want to go to the doctor? Happens all the time. Or why would you say I need to go to the doctor? My memory is completely fine. So what I tell people to do is to get in touch with their primary care doctor, nurse practitioner, whoever they see regularly on the down low, and tell them what is going on. Write a letter, make a phone call. They may not be able to tell you any of that person's medical information because of privacy laws, but you can tell them absolutely anything you want. And then we're very, very good at segueing. Oh, you didn't do perfect on this memory test. Let's just get you to the geriatrician just to see what's going on. When it's really significant, people really won't go to the doctor. Sometimes it's we're going to go get lunch and, oh, we're just going to swing by your doctor. They called and they must have forgotten to tell you about the appointment, but you have an appointment now. Let's all go together. The other one, again, if things are really bad, especially people without any insight and significant behavioral issues, are house calls. So Queens has a house call team that actually sees people that are truly homebound. And if somebody really refuses to go to the doctor, that would be a time to consider a trip from the house call team. When you're in an appointment, if your loved one or whoever you're caring for is not comfortable with you going through all of the behavior changes, the memory issues, that kind of thing, just give a note to the check-in person. They'll pass it on to us and we'll keep it quiet and go through all the questions that we need to and address everything without making the patient themselves feel like they're not seeing what's going on. There's going to be a big theme today of if you don't have to make an argument, don't make an argument about things. That is a huge takeaway. If somebody is safe and someone is healthy, there's absolutely no reason to make an argument. So you do not need to come to the doctor's office and say, Dad, that's not true. You did throw your glasses at me yesterday. What are you talking about? Write that down on a piece of paper, slip it to me, and I will know that it happened and we don't have to have an argument in the office. Usually it's not me having the argument, it's the child and the patient having the argument or the spouse and the patient, but nobody needs to have an argument. So these are commonly associated conditions for a person living with dementia, and we're going to talk more about these kind of one by one. But there's a lot of things that come with dementia. Again, broken record alert here. Dementia is not just a memory problem. It affects absolutely everything of a person's life, and how they think and how they process and how they interact with the world is part of that. So when somebody has a change in behavior issues, these are the things that cross my mind. And these are the things just kind of squirrel in the way away in the back of yours. Is somebody anxious? Is somebody frustrated? Is somebody in pain, or they're fatigued? They're not sleeping enough. When you think about it, any of us, when we are not in our usual routine, we're, got pain from a toothache, we didn't sleep well, we're jet lagged, we're frustrated that something's not going well. We're really not at our best either. Our brain isn't processing that well. We're not remembering that well. We're probably going to be short-tempered. That's going to happen to a person with dementia too. It's just the difference between when we have those moments and someone with dementia has those moments is much, much more noticeable. But it's the same root causes. People can feel out of control. They can feel like they don't understand. They can feel like other people aren't understanding them. I think, like a lot of us, over and understimulation can cause people to have what looks like behavioral issues and urine and bowel needs. I think, again, any of us, upset stomach, need to go to the bathroom, and we don't get to go when we want, we're a little bit more short-tempered. So think about all of that when somebody is having behavioral issues. And we'll talk more about what kind of evaluation is in order when that occurs in just a moment, but this is something that should be crossing your mind. And if you give us a call in the clinic and say, oh, I've noticed that my husband is doing this and this and this, we're going to run through kind of a long list of checkup questions to see if there's something we can pinpoint. So communication tips, again, if there's anything to take away from today, communication is a really, really big part of it. Because if we can figure out what's causing a person to be anxious, to be frustrated, to feel out of control, to feel like they're being heard, sometimes that can solve what looks like a behavioral issue. People with dementia, as their dementia progresses, don't understand the words that we're saying to them. It might not mean what we want it to mean. And so we may need to be creative about that communication, both how we describe things as well as how we get the information from them. Safety, safety, safety. If everybody is safe, everything is okay. So let's say somebody doesn't want to get in the shower and it's been 2 days since their last shower. Are they safe? Is their skin okay? Are they having urinary tract infections, rashes, pressure injuries like bed sores? If all of that is okay, they do not need to shower. You do not need to get into an argument about that. You can bring it up with their geriatrician or their neurologist and say, hey, how do I get this person to shower? Because maybe now we're looking at, and I see this, literally 2 months of not showering. How do I get this person's skin healthy? And then we can brainstorm and come up with some sort of creative solution. But people do not need to shower every day. As we get older, we actually do better with less frequent showers. It's better for our skin. So let it go. You don't need to have a shower that day. You do not need to correct things, and I'll talk more about this in a moment, but you do not need to correct things that are inaccurate unless it's a health or a safety issue. So if someone wakes up from their nap and says, I got a phone call, I have to go pick up my niece at the bus station, okay, that's a safety issue. We got to prevent that from happening. But if they wake up and say, I got to go pick up so-and-so, and you say, oh, they called just a minute ago and they're running late, why don't you come to the kitchen with me and have a snack? Then you haven't corrected them. They're not going to go drive anywhere and everybody feels heard. Sometimes if somebody has a misunderstanding of time or events or what's going on, you do not need to correct them because it's the kindest thing to do. So one of my patients, her husband passed away recently. And every time she asks the kids, where's dad? They say, he's in the hospital. He's doing okay. How are you? And all she needs is to know that everybody's okay. She does not need to be told over and over again that her husband has passed away, because every time they told her, she would go through the grieving process all over again. and get very upset at her kids. Why didn't you tell me that he died? So they just started answering, he's still in the hospital. He's doing okay. She felt heard, she felt seen, and that solved the problem. She didn't need to grieve every day or multiple times a day even. So this is a lot of what I was just saying, but if you can figure out what's causing the distress, if you can attempt to be patient and understanding, and I say attempt there because if you hear the same question 40 times in an hour, you're not going to be patient at least one of those 40 times with your answer because that's just human nature. So be patient when you can. Be patient with yourself. Be patient with the person you're looking after. Also, forgive yourself when you lose your temper. Again, if everybody is safe, it is just fine. There's nothing wrong with losing your temper. If everybody is safe, just take a breather, take a break, come back, try all over again. If somebody doesn't have the verbal ability, they cannot speak what they're trying to tell you, you can ask them to show you, or potentially you can take them around the house and try to figure it out with, walking them to the bathroom or taking them to the kitchen or showing them some sort of food. Sometimes as disease progresses, people have a hard time identifying what they're seeing. And then it's a little bit of guess what that person is trying to tell you. But once again, you do your best. Just try to be patient, try to figure it out. I kind of tell people, worst case scenario, give somebody a snack of sweet things if they like sweet food, because a lot of the time, if somebody is getting frustrated and somebody is getting anxious, giving them some sort of snack gives them a little bit of time to kind of reset. And then you can determine whether or not it's something that needs to be addressed after that snack. Really important, do not disregard how somebody is feeling. They are feeling it genuinely. And we need to make sure that they're being heard, even if we don't fully understand it. So when something like that happens, say, I hear that you are frustrated. I hear that you are scared. I hear that you're worried about this. We can't do anything about it right now. So let's go do this. Let's, get in the car and drive to Long's. Let's walk up and down the street, go for a quick walk on the sidewalk. Something that gets them out of that environment, something that gets them out of that mindset that they're stuck in. Again, don't argue. Doesn't get you anywhere. Most of the time, it doesn't get you anywhere. Usually it just escalates things. Everybody gets more and more upset. And then that's when we start having issues with things like aggression. A lot of the time, people hitting, kicking, that kind of thing. And I wrote this in here again, just because it really, really is important. But people past that early stage in their illness do not have insight. They do not have denial. It's simply a case of they cannot see that they have their illness. So this again is when explaining to them that they have dementia and they don't know what they're talking about is going to make things go very, very poorly. So don't. Okay. Anxiety. I contend that a lot of behavioral issues that we see for people living with dementia is actually undiagnosed anxiety. And when we've talked about all of those things, it makes perfect sense. There's a change in a routine. There's a change in a caregiver. They're anxious because something is sore. They're anxious because the home that they live in doesn't look familiar. And so it comes out like a behavioral issue when it's really a lack of understanding and anxiety. So if we can find something that redirects them out of that anxious situation, that is the best case scenario. Most of the time when we're talking about changing that environment in regards to anxiety, we need to get them out of both the mindset and the physical location. So if they're anxious in the living room, you may need to go to the kitchen, or you may need to go for a car ride, or you may just need to leave the house to go run errands so they can really reset things. And sometimes for some people, anxiety can look like pacing and wandering. So if somebody is pacing, if somebody is wandering, we need to see whether or not anxiety is the underlying cause there. I talked already a little bit about aggression. Again, a lot of the time people are aggressive because they don't have the words, they don't have the ability to put themselves in a situation where they feel comfortable and they feel in control and they are not anxious. So if you can, if the person can communicate in that moment, you can ask them, what's wrong? Why are you trying to hit me? Why are you trying to hit the caregiver? If you can, try to gently explain everything that you're doing while you're doing it. So if you're giving somebody a shower and they're trying to hit you because as far as they know, you are a stranger who's trying to take their clothes off and now they're trying to touch your privates. Yeah, I mean, any of us would hit or kick that person. That makes perfect sense. So if you can go through, and you may sound kind of silly to yourself, but it's still the right thing. I'm going to get your hair wet. We're doing a shower. I'm going to wash your back. This is your weekly shower, and just go through it over and over and over again so that person can remember throughout the entire experience what's going on and that they're safe. And if they have any questions or any concerns or anything like that, they can address them at any time. We see this a lot with incontinence care. So somebody who doesn't want their Depends or diaper changed, they don't want their bowel movement cleaned up. They may not want a bed bath if they're bed bound. So if you can talk them through it, that's wonderful. If not, a distraction is a great way to do things. Anytime you can get somebody out of their headspace, it helps with personal care and reduces the risk of anxiety and agitation. And again, if you are safe, if they are safe, it is okay. Nobody is going to get a bed sore. Nobody is going to get a urinary tract infection because you waited 10 minutes to change their Depends or their diaper. And if you need to take 10 minutes to leave the room, let that person reset, and then come back in, you've solved the problem. That's it. Safety is the goal. That's safety for you, and that's safety for the person that you're looking after. This is one that I find can be very distressing for family, and that's confusion related to memory loss. So when we traditionally think about Alzheimer's disease, we think about first short-term memory loss that progresses into long-term memory loss. But keep in mind that short-term memory loss starts eating into decades. So this is often when we hear things like, my mom doesn't know who I am. She thinks I'm her sister. Or mom doesn't recognize the house. They've been living there for 30 years. But imagine you're 80 and you've lost 30 years of your medium long-term memory. And you look over to somebody who's 50 years old and you're 50 in your head, that person cannot be your daughter. But you recognize them as someone in your family, someone you love, someone who's part of your life. And so it's a natural assumption to say, that's not a daughter, that's a sister. The same with the house. If you've lost 30 years and you've been living in that house for 30 years, you're probably thinking about a house from when you were first married, or maybe even the house you grew up in. And it's okay to say, we can't go home right now. I'm going to make dinner. Why don't you come into the kitchen and, pull out the napkins, or find something for that person to do so that they feel heard and they also feel like they have an activity. There's something that they can help with, a sense of usefulness, a sense of purpose. We do not need to correct them. Having that argument of, mom, this is your house, you've been living in this house for 30 years, is probably going to make that person feel unheard and maybe even anxious, agitated, and maybe even aggressive if we push it too far. Everything in life, as we know, is a question, is it worth an argument? Somebody with poor memory does not need to be argued with if it's not a health or a safety issue. And I realize, again, I'm a broken record. I did that on purpose. A little bit about apathy versus depression. So one thing that I also hear that's very, very frustrating for families is, my dad wants to sit in his chair and watch TV all day long. And as we've already heard from Dr. Masaki, watching TV all day long is terrible for us. And we know this. We know that when it comes to brain health and body health and cardiovascular health, heart, lungs, circulation, activity is incredibly important. And I tell people the best activities for brains are anything beyond excessive daytime TV watching and excessive daytime naps. So anything outside of that is fabulous. Sometimes, as I mentioned, people with dementia can have depression, and we need to evaluate that, and we need to treat it just the same as we would with depression for anybody else at any time in their life. So that's often an antidepressant type medication. But there's also this condition called apathy. And apathy is when people are perfectly content doing nothing. They're perfectly content sitting in their chair, not visiting with friends, not visiting with family, not exercising. And again, we know that this is not good for that person, but it's very, very difficult to treat. So what we need to do is first assess for depression, which is that sadness and no longer receiving pleasure from usual pleasurable activities. And if it's not depression, then we need to come up with a very creative solution that does not turn into an argument to get that person to have more activity. If there are grandkids or great grandkids around, hands down, these are the best people to make this happen because it is really hard to say no to little kids. So get them involved, play beach ball, volleyball, or beach ball, kickball in the house, something like that. Go to little kids' activities, soccer events, basketball, that kind of thing. If there's no little kids you can convince to do this, then it's creative problem solving, like parking further away from the front door and making them walk. It's asking them to help you do something. I have so much to do. Would you please match up all of these socks? Would you please fold all of these towels? Would you please put these non-breakable dishes away in the cabinet? Have them do something that they can do safely. Now, you may never find something that they put away in the cupboard. That's okay. You'll find it eventually. And that's something that you need to be okay with. You need to not correct them while they do things potentially wrong. It's very good for them. They'll feel a need of a purpose and they're not sitting watching TV. Hallucinations and paranoia. So this is very worthwhile to talk about because a lot of the time, this is what we'd consider to almost be a misinterpretation of reality. So I always give the example of, how we've all laid in bed at night, the lights are dim and we see something at the window and we think it's a person, but when we turn the lights on, turns out it's just something outside leaning up against the window. People without dementia can problem solve all of that. People living with dementia cannot. They cannot go those extra steps of, I need to turn the light on and look outside. So it's immediately a jump to, there's somebody outside. I need to shut all of the windows and shut all of the shades because the neighbors are all looking at me. It's a logical jump from one place to another because they don't have the problem solving capability in between. Sometimes with certain types of dementia, like Lewy body disease, these are very, very vivid hallucinations. And they can be really profoundly colorful things that they're seeing. I've had people tell me that they really like the new wallpaper in the house because they're seeing blue flowers up and down all the walls. It's not there. So that gets to another part. Do you have to give a medication or a treatment for all hallucinations? If it is not disturbing to them, it is not disruptful to the house, you do not need to medicate a hallucination if it's not a bother. We do not need to add medications to a person's list if they're doing okay. Sometimes the answer is, oh, I missed the kids that were running down the street playing ball. Were they having fun? Just leave it at that. You don't even have to lie about that if you don't want. You can just say, oh, I missed them. Just make a nice conversation out of it. If it is distressing to somebody, then yes, we need to give medications. We do have a lot of issues with people who have hallucinations worrying that one that I've heard a couple of times, like there's a little kid crying and it's really upsetting. We probably want to give a medication for that because that would be a tough thing for somebody to sit and have to live with. But if it's kids outside playing, we don't need to give a medication for that. That sounds like a lovely thing for someone to see. People with hallucinations, the majority of the time, do not know it's a hallucination, and it feels extremely real to them, and we need to acknowledge that. We do not need to argue with them. Again, especially if it's not an upsetting hallucination, we need to just answer whatever answer goes best with them. One quick moment about Charles Bonnet syndrome, which I have listed up here. There's a type of hallucination that's associated with eye illnesses, especially things like macular degeneration. So sometimes if people have what seems like a hallucination, in addition to a regular workup, I'll send them to their eye doctor so they can have an eye exam just to make sure that there's not something going on in their eye that's causing what looks like hallucination. And then paranoia can also be because of short-term memory loss. So imagine if, so okay, so good example here. So I left my cell phone back in the back. And I remember doing this. And if I go back there and it's not there, I'm gonna make a pretty natural assumption that somebody moved it or somebody took it. Now imagine your short-term memory is very poor and you in fact left it over here, but you remember leaving it up there and you go back there, it's not there, nobody ever saw it, nobody knows where it went. So it's a very logical assumption that someone moved it or stole it. So people lose things, either they hide them away or they put them a place they don't remember and then assume somebody else has stolen it. And that's a very difficult thing to treat because that's a memory problem. That's not really a mood or a behavior issue. We just kind of have to do our best to help find it or to help redirect them to think about something else if possible. Wandering is very worthwhile to talk about because this is a huge safety issue. I think we've all seen on the news seniors with dementia who have wandered away, sometimes never to be found, sometimes found days or weeks later having passed away. We need to make sure that we're keeping people safe when people have lost the ability to keep themselves safe. So medical alert bracelets with the person's name, the fact that they have some sort of memory impairment on there, and then in a case of emergency number. GPS monitoring, air tags, and tiles are lifesavers for finding people who wander. The tiles and air tags in the grand scheme are very inexpensive and kind of can be hidden on anything. You can put them in shoes, you can put them in pockets with safety pins. I've completely air tagged my children when we've been on vacation. You can make them watches, you can make them bracelets, you can make them necklaces, all sorts of things. And these work with your phone to help track somebody. Other simple things that you can do are stop signs. There's good evidence that putting a stop sign up will actually get somebody to not go through a door. If anybody's ever been in our clinic, the back door into our clinic by the bathroom has a giant stop sign because we've lost a couple patients into the cardiology department. That is now stopped. We have the stop sign. Reminders on doors, doorbells. So just a simple $30 doorbell that you can put on your door that rings anywhere in the house you want, just plugs into the wall, fabulous for knowing when someone's coming or going. The picture on here is something called a confounding lock. It kind of works like a lock in a hotel room. It folds over and prevents somebody from opening the door. What's wonderful about it is you put it in a funny place. You put it up either really high or really down low. Somebody living with dementia doesn't have the ability to problem solve that. They're not looking for anything there. And so they're unable to open the front door. But in case of emergency, anybody else can open it and doesn't even require a key. It's just a flap. And then if you have neighbors that you trust, please tell them about anybody that you're looking after's diagnosis of dementia. Because if you have somebody wandering, if you have somebody who looks more confused than usual, you want your trusted neighbors to know. Have I followed my neighbor who I know has dementia home from a walk? Yes, I have. Wanted to make sure she made it home okay. Okay. Sundowning. Sundowning is something that a lot of people experience, unfortunately, and it's worsening of behaviors. It's worsening of anxiety, worsening confusion that occurs in the afternoon or evening. And we think this has to do with circadian rhythms or your body rhythm with the setting of the sun and the loss of sunlight. The best thing for this is to keep a person on a routine with a lot of natural light and artificial light if need be. So leaving the windows open, leaving the blinds open, leaving all the lights on in the house. This can actually help. Leave this all on until basically bedtime. Alcohol and caffeine will absolutely make this worse. So most people with dementia should be avoiding alcohol completely. And most people, kind of all ages, should be avoiding caffeine after about noontime. And we'll talk about that in a second, because that gets us into sleep issues. So get a routine, go to bed at the same time every night, wake up the same time every morning. This should be for all of us, regardless of age or health conditions. This helps keep our brain as alert in the day as possible. So lights on in the day, dark and cold environment to sleep in at night. I absolutely believe in motion detector night lights for people because we don't want falls during the night, but up until their movement, either a low night light or a motion detector night light. Okay, so this is again for basically everybody, anybody with sleep issues, not just people living with dementia, but don't nap too much. For most people, that's an hour. I tell most of my patients no more than an hour in total. Everybody needs to be getting some sort of exercise, and it can be any exercise that that person likes and is willing to do. We all need to be getting sunshine. We all need to be getting outside and having that natural light for our body's rhythms. It's good for our mood. Exercise is good for our mood. It's good for our sleep. And it's just something that we forget is such a simple thing, but is so incredibly healthy for all of us. Most of us should be not drinking any sort of caffeine after about noon. And most of us should not be drinking much fluids about 2 hours before bedtime so that we don't have to get up and go to the bathroom all night long. Without a doubt, people are super prone to dehydration, especially as we get older. So it doesn't mean less fluid. It just means the fluid gets moved up earlier in the day. I had a long conversation with a patient and a patient's two daughters last night about this last one, just yesterday, about it is very common, almost normal for people living with dementia, that they can wake up from a dream and not tell the difference between a reality and a dream. And you just have to kind of support them through it until they wake up enough to know the difference. And it may be, like I was saying, that they wake up and start thinking about work, or they start thinking about driving or doing something. So again, keep them safe during that and wait until their brain wakes up enough to get more in the present. And then talking in your sleep, that is very, very common for most types of dementia. Okay, so this, again, I stole this from the Alzheimer's Association website, but I cited it. If you can try to identify the trigger, the cause, that's always worthwhile. Redirect attention, like we talked about. If you can create a calm and consistent environment, this is that routine, very worthwhile. Prioritize safety, prevent wandering, and then use the R method. Remain calm, reassure, and respond. This actually gets me directly to that third line down, reorientation, question mark. I find that putting somebody in the real world can make things worse. You do not need to tell them it's 2026 if they think it's 1986. You do not need to tell them that their parent has passed away if that makes them grieve. You do not need to tell them that they are retired if they're not actively trying to get in the car and drive to work. We do not need to correct people because a lot of the time that just makes them frustrated and anxious and feel like they're not understanding what's going on. So this is when the reorientation, not a priority. You know, get somebody a snack. Talk to them about when they were working. Ask about coworkers that they had. Oh, have you talked to so-and-so? You haven't talked to so-and-so in forever. How are they? get them in the car, go for a car ride, go get ice cream, go to Zippy's, just get out of the house, do something else. Maybe somebody really is fatigued and they just need a little nap. You know, maybe a half an hour nap is enough to help them reset and they're going to feel better. I do absolutely believe in pet therapy. So if you have a dog, that's another great time to get the dog, the cat over, you know, why don't you go feed so-and-so? They look hungry. Give them a snack. Something that makes them feel like they're being heard and again, being productive, doing something that's helpful for the house. I tell people in regards to constipation, constipation affects everything from the top of the head to the tip of the toes. So if somebody is constipated, everything is going to go poorly. So if we can get that person's bowel movements going better, their anxiety, their frustration, their appetite, their thinking, their balance, all of that can actually get better. So if you have somebody well hydrated and they're going to the bathroom on a regular basis, that's that time toileting, going to the bathroom so they're less likely to have issues with leaking and incontinence, and you get their bowel movements going on a regular basis, the world is a happier, healthier place, and everybody's going to appreciate the general health that comes with that. Okay, I'm wrapping up, but just a couple of medication slides in regards to behavioral changes associated with living with dementia. Okay, so the left side is the stuff to avoid. Anything with Benadryl, anything with PM, don't give. It will make thinking worse, it'll make behaviors worse, it'll make confusion worse, and it's a huge fall risk. So Tylenol PM, Advil PM, NyQuil, all of those avoid. And most sleeping medicines, so like the Ambiens, those types of things, Zolpidem, all of the medicines we call benzodiazepines, Xanax, Ativan, Valium, these most of the time make confusion, behaviors, and fall risk much worse. So if there is a change in behaviors, you need to have an evaluation. You need to bring that person in. It could be anything from going to make an appointment with your doctor or your nurse practitioner, or if there's a significant issue, it may be going to the emergency room. If you have questions about that, you know, give your office a call and run through what's going on so we can figure out the best place to go. But physical exam, we're going to do blood tests. We're going to do a urine test because something like a urinary tract infection could be the thing that causes this to spike. It could be something as serious as a stroke. If that's happening, we're going to send you to the ER so you can have an evaluation. And then please bring in all of the medications, supplements, over-the-counter vitamins, because maybe there's something that's interacting there that's actually causing one of your prescription medicines to cause you to be confused, or maybe your new prescription medicine is causing you to be confused. So we want to do that whole evaluation to figure out what's going on so that we can get to the root of the issue. When we treat, the most common things we treat with are actually medications for dementia. So Aricept, donepezil, Exelon, rivastigmine, or medicines like Namenda, memantine. Often we give medications. As I said, a lot of behavioral changes actually come from anxiety. So if we give medications like anti-anxiety and antidepressant medications, we can find that the behaviors actually get better with treating the anxiety. And if things are significant and we've run through all of these medications, we may be looking at stronger medicines like antipsychotics. This is like Seroquel, Abilify, Risperdal. These medications are higher risk, so we try to avoid them. And that's why we go through the lower risk things first. And again, anything you're taking, supplements, vitamins, all of that needs to be run through your doctor or your nurse practitioner so that we can go through and eliminate things that may be making it worse before we add something that we maybe don't really need to add. Okay. This is the real big takeaways for today. Not all behavioral changes need treatment. Is it distressing for the person living with dementia? Is it distressing for the person taking care of them? Is it a disruption to the house? Does it affect the caregiver's sleep? Is there a safety issue? If everybody is okay with the confusion, if nobody is upset, if everybody is sleeping okay, you don't need to give any extra medicines. So when I talk to the caregivers of my patients, I'll say, do you think we need a medication change? Do you think we are doing everything we need to do for right now? And if they tell me, you know what, we're doing fine, I'm not going to make any medication changes. But you have to think of the health of the house. That's any caregiver that's involved. That's also maybe daycare, if somebody's going to daycare, or a care home operator. We have to think about everybody. But if it's not something that's distressing or disruptful and everyone's sleeping, we don't have to give medications for behavioral changes. Okay. I mentioned this earlier. I think this is my last slide. You need to be patient. And that's not just patient with the person that you're caring for, but it's also patience with yourself, because you're going to lose your temper. And you need to forgive yourself, because that's human nature. One of the very few blessings about living with dementia is that somebody you've lost your temper at is probably going to forget that you lost your temper, and you can start all over. Lose your temper, take a break, go lock yourself in the bathroom for 5-10 minutes. Come back out with a smile on your face. Try all over again. Everybody needs to have support and respite. Everybody needs to have somebody they can lean on. One person cannot do it all. You absolutely need to lean on, like, the organizations that are out in the lobby. You need care, you need respite. And whatever that ends up being for you is the right answer. If that's friends, that's family, if that's care home, if that's memory care unit, if that's adult daycare, whatever is right for you is absolutely the right answer. There's not a one size fits all. And I think that's it. And I have no idea how I did on time.
Oh, you're perfect. Thank